everybody. Welcome to the Technology Evangelist podcast. I'm Dr. John Fluke, Technology Evangelist, and we are brought to you by the kind folks at Medidenta. So Medidenta.com for dental supplies. It's a great team out there. I love working with them, and if it wasn't for them, I wouldn't be here. Also, a selfish request, like and subscribe. Leave a comment if you want to. All of that helps the algorithm, which, as we all know, they run our lives now. And with all of that out of the way, I have got a really special guest with me today. I met him for the first time a couple of weeks ago at Marty Jablow's Dental VIP Summit in Chicago, right before the midwinter meeting. And I asked him to be on, and he was like, yeah, I'll do it in a heartbeat. So, ladies and gentlemen, the immediate past president of the American Dental Association, please help me welcome Dr. Brett Kessler. Brett, thank you for being here today and taking the time.
Thanks, John. I've known you for many, many years, and we've just never actually intersected until we were in Chicago 2 weeks ago, and sure glad we did, and happy to be here. Yeah,
well, thank you. You know, it's funny how the ADA works with this is that I've been ADA member since I was in dental school back when dinosaurs walked the earth and there was no dirt because the rocks hadn't, broken down into soil yet. But I went to school with a doctor named Cesar Sabates, who I think 2 or 3 years ago was president of the ADA. And it's kind of a wonder to me that our paths never have crossed. So thank you. The way I always like to start, Brett, is I call it the Wayback Machine. So
okay.
My history or my story goes back to I was 3 years old when I decided to be a dentist. So wind it back as far as you'd like to go and tell me how you got to where you are now.
Starting from where how I became a dentist, that kind of thing,
just whatever got you interested in it. I mean, I literally extracted one of my sister's primary molars when I was 3 and she was 9. So that got my start, but just go back as far as you want.
Did you bill for that, and did insurance cover it? I just want to know.
The true story is, and I think I've told this on here before, so you can fast forward if you want to, but so we were having breakfast one morning, and my sister, 6 years older, had a loose primary molar, and she kept complaining about it during breakfast, and my mom and dad were like, well, just pull it, and she's always been squeamish. She's like, I can't. So we got done with breakfast, and a little light bulb went off over little Johnny's head, and so I took her into the bathroom right off the kitchen, and I put the lid down on the toilet, and I had her sit, and then I went over to the sink, and I washed my hands, and I got the little footstool that all kids have, and I climbed up on it, and I said, which one? And it's this one. And I kind of reached in and poked it. It wiggled a little bit. I got a hold of it and went, whoop. And my sister was like, oh my gosh, it didn't even hurt. So I went in, and my mom was doing the dishes, and I still remember it. I'm 3 years old. I walked in. I was like, Mom, look. And I held my hand up, and there's my bloody little fingers, with this thing in it. And I remember the look. What I really remember is the look of complete terror on my mother's face. And she's like, what have you done? And I said, it's Connie's tooth. I'm going to be a dentist someday. And no, I didn't bill for it. It was, I did it gratis. It's kind of
nice.
Professional courtesy.
Nice. Well, I'll come back to that with doing dentistry on family in my story. But, I went to University of Iowa for my undergraduate studies in biomedical engineering with the goal of going to medical school. And I remember one summer I was studying for my MCATs for most of the summer. And I remember having the MCAT application in my hand, standing at the mailbox, and I realized, you know what, I don't want to do this. And I tore up the application right then and there.
Wow.
And so I kind of floundered around for a while. And one of my fraternity brothers, who happened to be in dental school at the time, said, Brett, with your engineering background, you'd probably do pretty well as a dentist. You should consider that. And the girls are cute. And and I knew that because I had been to some of his dental school class parties, and they had some, cute girls in the class that were studying to be dentists, and it attracted me to explore it, and I quickly shifted everything over to studying for the DAT, and I did really well at the DAT. And then I said, well, I was really kind of lost too at that time. I wasn't in a good mental space. I don't know what you guys know about me, but I entered dental school with a substance abuse problem, and I graduated dental school with a worse one. But I was pretty messed up in that time in college. And, so I was just kind of partying all the time. But in my engineering classes, out of nowhere, we started having dental school professors come over and show us like dental implants, and I didn't know anything about it. And all of a sudden people had no teeth, and all of a sudden they had teeth, and I thought that was dental implants. And then one of my biomechanical design projects in my 5th year of college, because again, I was kind of screwing around a lot. Right. One of my design projects was to determine the force distributions in bone from a dental implant, based on different trajectories and different vectors. And it was pretty intriguing. And then I started, I think I'm going to do this. And I go back to all that I knew about dentistry was, as a teenager, I had a crush on my hygienist. So I'd eat Oreos before I'd go in for my cleaning, so she'd spend more time with me. And, you look up and it's like, And, but that, and then the dental school professor starting to come over, I'm like, I could do this. And then I said I was going to go to the only dental school, the first one that accepts me is the one I'm going to go to. And when I got my DAT score, I got a letter from one of the schools. So this is before the internet. So nothing was, everything was mail, letters and stamps and things like that. And the first school said, we saw you did really well on the DAT. Please consider applying to our school. And I was like, okay. And, so I sent a check in for $25, and I, did my application, and like literally I saw that the check was cashed, and I got the letter of acceptance that same day. I was like, oh, well, wow, it was that easy to get in. I better rethink this. And so I ended up, going through a couple different interview processes, but everywhere I applied and got an interview, I got in. And back then, it was the early 90s. It was much easier to get into dental school than it is now. I think the ratio was 1 slot per applicant at the time. So they were really hurting for dentists and dental students. And, and now it's 10 applicants per slot. So it's much more competitive than it ever was. I would not be able to get into dental school in today's days. I did really well on the DAT, but, engineering was hard. Anyway, so I got in, and I did really well, and the girls turned out to be cute. It's where I met my wife. She was a classmate, and we got married our 4th year. And so, and then got into private practice. I did a general practice residency, which was very pivotal in my leadership. One of my big pillars as president was to find ways to reconnect the mouth to the body, and through the systems involved, like payer systems and things like that. And so I was, foundationally, I learned about how important oral health was in overall health. And when there were systemic problems, systemic diseases, what were the oral manifestations, and if there were oral problems, how it affected the systemic diseases. And I truly did, see the connection and how we can help with our patients. So anyway, I hit, that was an amazing experience for me, and tools that I use for my GPR and every single day in private practice. Moved to Michigan to be with my wife after my residency. She was studying orthodontics at University of Michigan at the time, and I was working in Flint, Michigan. And I got a job with a very, very good dentist who was Panky Dawson trained, and he kind of mentored me along that route about comprehensive care, and again, that also was very pivotal in my leadership trajectory as well. A few years later, we moved to Colorado, and I hit my bottom in Michigan, where my substance abuse consequences started to really catch up to me, and I got out of control, and I was literally at this crossroads of, do I want to live? Do I want to die? Because I had went to rehab. I had made a call to the Michigan Dental Association Wellbeing Program, and they guided me to help. Wow. And I went to rehab. But when I got out of rehab, I didn't get sober yet. And it took me another year to really hit my bottom. And I get pretty, I'll be forthright with what happened. I was working in Michigan, and I brought my staff to Chicago for a dental meeting. And I had a drug dealer in Chicago, and I disappeared. I bought a bunch of drugs and I disappeared and left my team hanging. And that was not good. And that's when I really started to get, I'm like, this is not working. This can't go on. And I started embracing what I learned in rehab and taking it seriously. And I'm 27 plus years sober. To me, it was one of the best things that's ever happened to me when I finally got sober, and I had to rewire my brain, and because it is a brain disease. Yes. My brain is not different, is much different than a normal person with regards to substances. And so to override those pathways, I had to develop a mindfulness practice that was, prescribed in my treatment center. It was prescribed through my recovery program. And it was the best thing that's ever happened to me. And when I broke out of the addiction and got better, I saw this, I got this world in front of me that is just full of infinite possibilities. Because when you're in addiction and mental illness, your world is very small, and its sole focus is to get more drugs or get, whatever your addiction is. And when I broke out of that, I was like, man, I could do anything. And so I really took advantage of that. And, and I started my own practice in 2003. It was a fee-for-service practice in northeast part of Denver. But when I applied for my license in Colorado, they put me on probation. And I didn't realize it was a punitive measure. I was ready to, I shared everything with the board when they asked those questions. I felt if I was going to, practice in Colorado, I wanted to, not start with any kind of, having to look over my shoulder about who I told lies to. I was forthright with everything. And I was proud of the work that I had done. I was a little over a year sober at the time. And I knew I was going to go into a monitoring program, and I welcomed it, right? It was the cost of doing business. And it turned out to be a great program for me because, I had to do random drug tests. I had a practice monitor that came and, just kind of made sure that I was practicing at or above the standard of care. And he turned out to be a very big mentor to me over time. And then I had a track record of sobriety. And, and it was great. And so I welcomed it. But then I got in trouble. I got a letter from from the state of Michigan, a letter of admonition and with a fine of about $1,500. And I was like, so I called them up and like, what happened? Why am I in trouble? Well, you were on probation in Colorado and you didn't report to Michigan. You still have an active license. I'm like, I'm not in trouble. I'm just being monitored. Yeah, no, probation is trouble. And, but I didn't do anything wrong. I just sought help. Why am I getting in trouble for seeking help? And that question, it pissed me off. Sure. Okay. And so I went back to Colorado. I went back to Colorado and said, hey, I just want to let you know that I'm in trouble in Michigan because I got in trouble in Colorado and I didn't know I got in trouble in Colorado. And I don't want to get in trouble again because I didn't report to you, that I got in trouble in Michigan. And so that, and so that turned into, me getting active in advocacy. Okay. And about 3 years into this, I joined the Colorado Dental Association, first of all, the well-being program, but also they were doing what's called a sunset review. So every 10 years, they update the Dental Practice Act to bring it up to that day's standards, over the 10 years. And one of the things in the Practice Act that I wanted to change was this punitive, attitude towards people who are seeking help. And so I became an advocate. It was the first time I came out professionally about my little secret. But I'll tell you, the people in the room, the leaders in Colorado in that time, they welcomed me with open arms, and they fought with me, and they encouraged me. And there's a lot of stigma that is attached to addiction and mental illness, and especially in dentists who are type AAA personalities who don't like to fail in anything and, show any signs of weakness. But here I am getting vulnerable, and they just welcomed me with open arms and guided me and kind of over the years pushed me into leadership. In my private practice, I had this high-end Pankey Dawson style practice. Right. Okay. But I was still going, and I still do go to recovery meetings. It is the most important thing in my life. And I treat it as such. But I was treating people from the rooms of recovery who had dental problems. And I started a program with a treatment center in downtown Denver called Sobriety House. And it served a homeless population. And it got them off the street, it got them sober, got them fed, got them healthy, got them clothed, vocational training, and got them back onto work, okay, and back into life. And it was great, but they still had the scars of their addiction on their face. Their teeth were really bad, and a lot of them were in pain. A lot of them were missing front teeth, or had chronic perio disease, inflammation, all that. And so I made a deal with the treatment program that if they kept them in treatment, because it was a homeless population, it was very transient, I would do their dental work for free. And it turned into an amazing program, and made a great impact. Over time, other treatment centers started asking me for similar services, and I couldn't do that because I was trying to build my private practice and couldn't give away everything. And so I called Metro Denver Dental Society and asked them if they knew any dentists who were doing this kind of work. And they're like, "Wow, no, Dr. Kessler, but it sounds like a great program. Let's do an article in the journal and see if we can get other dentists to join in." And so they wrote a beautiful article, and a couple other dentists came out of the woodwork and started helping with these other treatment programs. And then that turned into Metro Denver Dental Society started a foundation called the Smile Again program, where it started treating people who were suffering from substance abuse and domestic violence. And there were about 700 volunteers in Denver doing this work, and it was awesome. I felt really good about the impact we were making on, people that were just like me. I just happen to have a degree. Yeah. And these are people that fell through the cracks. A couple years into this, a Metro Denver Dental Society calls me up and says, we have a reporter asking us if they know of any dentists who treat meth mouth. And so we called you to see if you knew anything about it. And I said, yeah, I've been treating it for several years now. Sure. Would you like to go on TV and talk about it? No, I don't want to do that. I didn't want to be known as meth mouth guy. I wanted to be known as veneer guy. That was the type of a practice I was trying to build, and I was afraid it was going to ruin my business. And so I had some mentors. I had a recovery mentor who said to me, he's like, Brett, it's very rare that they ever spotlight and highlight people in recovery in the media in a positive way. And the work you're doing, you're changing people's lives with the work you're doing, and we can illustrate that recovery is possible, And then I had a mentor from my Pankey training who said the same thing. Brett, it's very rare that media portrays dentistry in a positive light, and here you are making big impact on people, and blah blah blah. And so I went on TV, and it turned into and I had a couple of my patients from Sobriety House who were doing really well, and they were both homeless before, and now they're just thriving in life, and they got on TV and they just talked about how amazing of an impact the dentistry was on their recovery and on their lives, and now they can actually smile, and their insides meet their outsides, and the scars of their addictions were no longer on their face. Several other media outlets did similar stories across Colorado. One of them got picked up by CNN and it went national, and it was on headline news. So 19 minutes after the hour, every hour for that weekend, there's Brett upside down working on meth mouth, and the ADA caught wind of me there. Okay, and so here I am. I'm about 10 years sober. I'm not in leadership in any way, shape, or form. I had no interest in doing that. I'm just doing my thing. I'm training for triathlons. I'm living my best life. I'm a dad. I'm a husband. I'm a business owner, and so the ADA out of nowhere calls me up and says, "Hey, we saw your stuff on CNN, and we're doing a bill in DC to help fund dental treatment for people in recovery, specifically around methamphetamine. Would you come to Washington, DC and testify before Congress?" And I was like, whoa, when you think about like important timelines in your life, and this was one of them, because gosh, John, like 10 years prior, I was ready to kill myself. And I didn't know if I wanted to live or die, let alone be a dentist. And here I am 10 years later, the most influential, organization in the profession of dentistry is asking me to come to the U.S. Congress to talk about something that I know a lot about that can make a big impact on people. And I did it. And it was just, again, it was wonderful. It didn't happen. The bill didn't pass. Nothing ever passes in DC. But that's a whole other story that we'll get into. But I came back from there, and and people in Colorado, especially leadership, saw me more than just the wellness person, because I was the guy now answering the phone when people were hitting their bottom. And over the years, I've directed hundreds of our colleagues back to life and practice, and I've been an outspoken advocate. But they asked me to join their leadership team. And I became president of the Colorado Dental Association 2012, 2013. And one of my, again, I really started getting into advocacy and how powerful my voice could be. And I was part of the team. One of my proudest things that happened while I was president, I was part of the team that developed a dental benefit in the Medicaid space for adults in the state of Colorado. And so now 300,000 people had access to care that didn't have access to care before. And it was comprehensive. And these were my people. These were the same people that were, at the sobriety house. They fell through the cracks, and we were able to provide for them in big ways. And so the Smile Again program, foundation, dissolved because we didn't need it anymore. And so it was really, really special. And we still, and I'm biased because I'm from Colorado, but we have the best Medicaid program in the country. We're paid very well for our procedures with minimal administrative burden, and we can do comprehensive care on our patients there. And it's amazing. Power of one voice. From there, the trustee at the time, Dr. Gary Yanamoto for my district, said, Brett, we want you to join a council at the ADA, a council on dental benefits. And I'm like, well, Gary, I don't know anything about dental benefits. I'm a fee-for-service guy. Okay, I'm doing veneers and full mouth reconstructions. I don't know how to file claims and things like that. He's like, no, what you did with Medicaid is what we want you to bring to the ADA. We don't do enough to provide access for those that don't have access. And, that's where we want you to help out. And so I did that for 4 years. I was on the council, and I got to learn the ins and outs of the benefit industry. And, and I got to, talk to executives of insurance companies and tell them that their benefit systems suck and they don't work, and whatever. And so I was able to advocate along that way and try and make a difference and develop strategies for the ADA to really combat the benefit system that we're in. And then came up to the point where I decided to run for trustee from the district. And I won that election. And so 4 years as a trustee, I decided to run for president, and I won there. And hot damn, that was never thought I'd win. But honestly, my goal was just to plant seeds. Yes. And I never thought, I know my brain and my ideas a lot of times are way ahead of what people in leadership were ready to accept. But if I can plant seeds, I got this one opportunity in this campaign to go around the country and tell the leaders, my view of the future. And talk about wellness and talk about reconnecting the mouth to the body and talking about, trying to find ways that every dentist feels comfortable under the umbrella of the organization. And like I said, I didn't think I would ever win, but I did. And then, I became president, and it was one of the most challenging years of my life. But it was honestly, John, the best year of my life, because I did my best to show up every single day to drive the profession forward in ways that it needed to. And I feel like very, very proud of the accomplishments that we had, under my term and where we're going as an organization. Coming back full circle to my recovery, those mindfulness, tools that I used helped me be the best leader I can possibly be. It helped me discover what my core values are, what my vision is, what my mission is, and how it relates to the organization. And I was very clear on all that. And so all the drama that we faced over the last couple of years, it was a challenge, and there was a lot of disappointments there, but it didn't derail me from really pushing the profession in the way I felt it needed to. Well, so I'm going to take a breath there.
Okay. No, that's super, because the thing, our stories are completely different, because I had a mentor in dental school that I really looked up to. And she said to me, when you get out of school, make sure, I was part of the ASDA, but she said, when you get out of school, make sure you join the ADA. Uh-huh. And I said, why? And she said, because we need a voice, and it's the right thing to do, Fluky, so just do it. And I never questioned that, really. I just, yeah, okay. But your story is totally different. You came at this from a totally different perspective. And one of the things that I thought of when you were talking was that, it's such a weird dichotomy, because the boards, they feel obligated to protect the public. But at the same time, so many people are suffering. And I think, now I could be wrong because I've never been through treatment, but I think if you work for a corporation and you say, I need help, and oftentimes corporations are like, no problem, we pay for treatment, or, when you get out, you're going to get your job back, all those kind of things. And with any kind of a licensed professional, it almost is I don't want to say impossible, but it's so difficult to step up, because you've got the stigma and you've got the monitoring, and everywhere you go, fill out this form to be an insurance provider, and they want to know all of that stuff. And you've got to explain yourself. And there's this, I just kind of picture this big black cloud. And so a lot of people, I would think, would be like, I can hide it. Right. Why do I want to go through all that? And yet, I think a lot of younger dentists picture organized dental members and people that rose to a high level like you did, like, oh, well, they probably wanted to be in politics when they were younger, but they just couldn't afford to do that. So they're these, schmoozy people that really what's important to them is the schmoozing. And it's not, what are they doing for me? And yet here you are. And this is exactly why I believe in organized dentistry is this voice. And, I don't care what your job in dentistry is. Whether you're private practice, whether you're an associate, whether you're working for a big corporate organization. One of the other great things that one of my mentors told me, and this is kind of a cool story, was that a patient came in and had something go wrong somewhere. And he just fixed it. It was no big deal. He just fixed it. And when the patient left, he looked at me and he said, I could have really bad-mouthed, what happened. And I said, yeah. And he said, what's the point? You know what? It's fixed. Somebody probably had a bad day. And, why should I punish them? We need to take care of ourselves. We need to treat each other right. And I just think that's so important, that it's. So my whole thing is that organized dentistry does incredible good for us. A lot of it behind the scenes that people never see. And yet it's always there. It's kind of like your dental guardian angel in a way. It's working for you whether you realize it is or not,
Yeah.
And,
yeah.
You had such a cool way of getting into this where you were like, doggone it, somebody needs to do something about this. And you did. And I don't know, moving, it's inspiring. I mean,
thank you.
How many people have you helped simply by having the courage to be open about that?
Yeah, that's the one thing that I learned about it, because again, it was so much stigma, so much shame.
Yes.
And at one point I recognized, I'm living my best life. My sobriety is the best thing that's ever happened to me. What am I ashamed of? I'm not that person that I was when I was in my addiction. I'm a different person now, and I'm proud of who I am. And why not share that? And when I started sharing it, I always got these side conversations. Hey, can I talk to you, privately? Yeah. And it's always, I have a friend who is struggling, or I have a daughter or son that's struggling, or, and every once in a while I got, I'm struggling. Can you help me? And so, I always say a little prayer before I share my story, that somebody hears something they need to hear through my words. And so that, and inevitably someone always hears something they need to hear. And so I'll just share that I won an award this past week with the Denobi Awards in Portland.
That's amazing.
And I was so humbled. 5 minutes before the award was announced, I get a text from somebody who I helped a year ago, thanking me. I hadn't talked. She's like, I haven't talked to you in a long time. I just wanted to let you know that when you talked to me, it changed my life, and I'm doing so much better today because of that. And then I was like, see? And then I won the award. The day could not get any better, but it's just like, I don't do it for the awards. I do it because I know the power of sharing, and the power of being vulnerable and human allows other people to be vulnerable and human too. I've never regretted sharing it. And again, I would say it's my superpower. It gave me the courage to be, go after the big things, okay? Because every day for me, it's like bonus day. I should be dead. And so it's like, I got nothing to lose. I should be dead. But I do want to say, my first job, my boss had the similar talk with me that your mentor in dental school said to you. He said, Brett, if we are to remain a profession, everybody has to do something. At very least, you need to be a member. And as a benefit of working here, we're going to pay for your ADA membership. I'm like, okay, whatever. It didn't mean anything to me at the time, but until it did. And that's the wonderful thing about organized dentistry, is that we do so much for so many. Everybody has a different value proposition of why they value the services that we can provide for the profession. And it's not just one. It's no big blanket. It's a whole portfolio of things that are different for everybody, and we respect that.
This is an interesting deal. During COVID, I got really lucky. I don't know how this happened, but ADA had a Zoom call, and they just invited people. And I think it's probably because I was working with Dental Products Report at the time, and probably they saw editor next to my name, and they'd be like, "Oh, well, he'd be a good guy to have on the call." But I was on this call with between 50 and 100 other people, and they just spent time talking about what the ADA was doing, to help the profession just during COVID. And I sat on that call, and I remember, gosh, I'm embarrassed. I don't remember the gentleman's name. He's the one in charge of our lobbying in DC. I'm
so that was Mike Graham at the time.
Okay.
It was Mike Graham at the time.
So Mike started talking about, well, we've done this, and we're talking to this senator about this, and I just met with this representative last week, and I told him this. And I just remember literally thinking to myself, I wish every dentist in America was on this call, because there were so many things being done that I didn't know about. And I was like, oh my gosh, this is worth like every penny that I've ever paid, in my career for the dues, just to learn this. And there's so much that goes on in the background that you don't, as a dentist in the trenches that's paying their dues, you don't realize all that stuff. Who is, help me out, Brett, if you don't know, it's okay, but the senator in Maine that is such a dental advocate, do you know her name? I know it's a female senator. And it's okay. I just remember Mike saying, every time I talk to her, she says, don't forget, I'm the senator that's all in for dentistry.
Right.
And I was just like, that, there's only 100 people doing that job, and one of them is saying that. That's exactly why we need the voice. And I know that, the organization went through some tough times and probably is still going through some tough times. And it's sad, but at the same time, I've been so proud of the organization for the transparency. I mean, it seems like, I don't know, once a month or something like that, I'm getting emails from leadership, and they're talking about, here's the problem, this is how we're fixing it. And it's not just this thing of, oh, nothing to see here, look at this. And I think that's terrific too. I think my biggest gripe, not with the organization, but with my peers, is that, and this is one of the reasons I wanted to talk to you, was that
sure,
it's just getting people to realize what the ADA is doing for you. Even if you're working 1 day a week, the ADA doesn't care. Even if you're not practicing, or even if you're not a member, it's still out there. That thing is still working for you all the time. And how many banks give you interest on money you don't put into it?
Right.
And that's kind of my thing, is that, in a way, I think that COVID call was kind of an awakening for me. I just was a member, and I was president of the Greater Kansas City Dental Society and that sort of thing, but I never moved up. But I just was like, oh my gosh, if everybody knew everything that's going on, I feel like in the past couple of years, it's been kind of a case of, I do it right, nobody remembers. I do it wrong, nobody forgets. Which is kind of the cardinal rule of clinical practice too.
It's our culture right now, and my first year on the board was COVID, and so I got to be, I got to be in the room, in the decision room on some pretty big things over the last couple of years, and we were, obviously very concerned about COVID, but just like the rest of the country, there were a lot of debates going on in those four walls. Is it really the flu? Is it really a virus that's going to be a problem, or is it just a bad flu that we'll just get through? And and one day the government calls us up and says, "Hey, we're shutting down dentistry." And we're like, why? Well, what little we know about the virus is that it lives in these aerosols, and you guys produce aerosols, and we need to lower the curve. Remember, lower the curve.
Oh, yeah.
And you need to do your part. You need to give us all your, protective equipment, your gloves, your mask, and all of a sudden this N95 mask type became a thing that nobody had ever heard of before. And so what happened, we said to the government, listen, we know that this virus is coming, but we also know that dental disease is going to progress regardless of the virus or not. And we need to be open. They're like, nope, you're going to be closed. And if someone has a problem, they just go to the ER. And if you remember back then, nobody went to the ER for anything. No one, because that's where, I don't want to catch COVID from there. And the ER would tell you, if you think you have COVID, definitely come to the ER, but do not get out of your car. Come to the roundabout, open your window just a little crack, and they're getting some guy in a space suit came out and he had this long Q-tip and he put it through the crack in your window and put it up your nose and turned it around, and then a couple hours later you found out if you had COVID or not. And I kept thinking, this guy's in a space suit. What is he scared of? And we're just practicing in our scrubs and things, and so but we really pushed the government, saying that even if they went to the ER, they don't have the capacity to treat anything dental. So we need to be open. And we declared ourselves essential healthcare right then and there. And so the ADA, we divided our entire organization into 3 sections. One was to advocate to make sure that we had financial stability to keep our practices running when the pandemic, when we're allowed to return to practice fully. Okay. And then we had 1/3 of us going into the science, learn all that we can about this virus, learn all that we can about the behaviors of the aerosol sprays and things like that. And so we put all that in front of the firewall. So, open access for the entire world to access, because we had a ton of research on that. And then the other third went to figuring out how can we practice safely. We have success in practicing under duress. We learned about how to do that with in the AIDS, HIV times in the 80s and 90s. And we learned how to do it in the SARS virus in the early 2000s. And we did it really successfully. And, and we did it really successfully this time with COVID. And, I think there was less than 3% transmission rate in the dental office, where if you in a hospital, there was a 35% transmission rate. 35% of you, if you're in a hospital in any way, shape, or form, 35% of you got COVID, less than 3% in dentistry. We did it right, and we did it well, and we did it safely. And we played our role in a time of crisis where we need to be in the delivery of healthcare, and we declared ourselves essential.
I just say, rightfully so. I mean, it's funny, and this is just a story. I'm not trying to make myself out to be anything more than I am, but I worked by myself. I went in, I think it was 2 days a week, and excuse me, I had some team members that were like, I'll come in. And in the early days, I was just like, no, I looked upon it as, when I went into this field, I went all in. I mean, it's a little bit, the way I felt was it kind of like the military. Even if you're an accountant in the military, you do sign up to be shot at, if the worst case scenario happens. And so I felt like I kind of signed up to be shot at. I didn't feel like my dental assistant signed up. And so I was doing endo by myself, trying to find everything and trying to work alone. But people needed that help. I mean, people call you with a toothache. What are you going to do? You can't send them to the ER. I have actually loaned anesthetic textbooks that I got in school to ER docs so that they knew where to place local so they could at least get people out of pain. That was no place, for them to go in that situation.
Exactly.
And we are essential. And the whole mouth-body connection, I spent one episode talking to Ed Zuckerberg, who, golly, that guy has done a deep dive on the whole oral microbiome and the connection between everything. In fact, I'm going to have him on again because we couldn't cover it in an hour. But just that whole thing of how it all goes together, I mean, why did that take so long? That's one of the great questions I have. When I was in dental school, there was a lady that worked in the education department, and she was kind of a cartoonist. And she had this great picture on her wall that she'd drawn of a human with this little tiny head, and it said how physicians see the patient. And then there was another picture with a little itty bitty body and this huge head and huge mouth, and it said how dentists see the body. And that it's all connected, and that information needs to get out. I mean, we're seeing it more and more now, but just having that whole thing of oral health directly affects overall health. I mean, the mouth is connected, and people need to realize that.
And the research, 10 years ago was kind of fringe on things. Okay. But now it's robust and it's compelling. And we've got this great opportunity here as essential deliverers of care. Okay. Yeah. And it's time to reconnect it. I believe, again, bashing the current benefit system that we're in. I believe it's causing a lot of problems, and it's not comprehensive. It's not essential. It doesn't reflect an essentialism that we are. But 90+% of us take it. But 100% of that 90% all hate it. Okay. But please, but I'll tell you that we all took it. Okay. I was mostly fee for service my entire career. But we took it and we did really well with it. Even though we hated it, we did really well. But they have not kept up with, the cost of living. The benefits have not improved in any way, shape, or form. Right. And it doesn't reflect the essentialism that we are. And as a result of that, we as business owners, we as dentists can't offer our team the career opportunities we used to be able to offer them when we first started our practices, because now it's, we're just getting by. And, my dental assistant wants a raise. It's a new year and cost of living's gone up, and, but yet the cost of a crown hasn't gone up, or the reimbursement for a crown hasn't gone up. But yet my rent went up, my electric bill went up, my materials, dental supply company bill went up, but yet the benefits haven't gone up, whatever. And it's just not working. So, the dentist has to, cut where they got to cut. And so that's what I think driving our workforce issues, because, it's, especially in the hygiene world, I applaud them. They found ways to, on the temporary services market, they can make what they made 4 days a week. They can now make it on 3 days a week. Yeah. And dental hygiene is really hard on their bodies. And, and they can work less and make the same. They're going to do that. And, and so I don't blame them. But we have to figure this out. And I think that the only way for us to figure this out, and we're doing a lot of advocacy work to change and improve the benefit system, but it's going to take an entire paradigm shift. And it's not happening quick enough.
No, and one of the things that concerns me is even back when I was in school, there were 120 graduating doctors in my class, or close to that. We graduated 20 hygienists that year. Right. Yep. And that hygiene deficit, we need dental hygienists. I think I want to say 40% of dental hygienists work part-time, and God love them. Like you said, I would work part-time if I could. But we need more. One of the things that concerns me is, what are we going to do with all these folks in nursing homes now? We're living longer, and more people are living in facilities where they can no longer travel. My dad was in a nursing home, and they had a dentist that came in one time a year and handled the emergencies. And, that we've got to have people that can go out, do data gathering, so to let people have a quality of life. I think one of our problems is we talk a lot just in healthcare in general about access to care. I really think what we have on the business end is access to care. as long as the bottom line is good, don't change a thing. Well, that isn't going to fly. You've got to be reimbursed enough to be able to do the things you need to do. And if we don't have the team members, if we don't have the long-term team members, if every year I'm losing an incredibly qualified dental assistant because Target will pay them $1 an hour more,
with benefits and vacation.
Yeah. I mean, it used to be in the old days, I used to pay 100% of my staff's health insurance.
Yeah.
But there's no way a dental practice could do that now.
Right. It's prohibitive. And I think we are failing as a profession because less than 50% of our citizens in America have, access dental care. And, much of it is due to finances and benefit systems. And, and I don't know where it became so acceptable for us as a profession to take less money to work on poor people or to take less money to work on old people. Right. Dentistry is hard. And in order to provide our best care, these systems need to be funded appropriately. And anything that we advocate for, whether it's a dental benefit in Medicaid, whether it's an expanded dental benefit in Medicare, whether it's improving dental benefits in the private sector, that we need to be paid an appropriate fee. We need to have minimal administrative burden. We need to have a comprehensive approach. We need to have patients should have choices in who they can see. We need to have minimal risk of audit. Okay. And that's what we've been fighting for. But yet it's really hard because so many dentists still take the benefit system that we're in. 90% of us take, one or more plans, and 100% of that 90% hate it. But we take it because it drives people to our practice, and culturally the patients, think they depend on it. They need dental benefits to come, and many do, absolutely. But to do the kind of care that we really wanted to do, the kind that I like to do was, complex reconstructive type stuff. The dental benefit system didn't work for us, and my patients were able to pay out of pocket for things, but that doesn't work for the masses. And so we have to find ways to fix that. And I spent, last 8 years working really hard in that realm. And I think we've got a great plan on where we're going with that.
So, and that's one of the things too that I think is important for dentists. I would emphasize, especially younger dentists, is that unfortunately big ships turn slowly, and this whole thing of third-party reimbursement. I can see the efforts, and I think it will get better, but it takes time, and you can't expect that I pay dues this year and all of a sudden, the earth shifts and suddenly I'm being paid what I'm worth. But there are people out there that are trying to get you paid what you're worth. And if success happens in little increments at a time, I have kind of a joke, but it's true. I say life is like orthodontics. If you apply gentle pressure over time, things end up the way you want. But if you try and move the teeth in a weekend, nobody's happy. And that's kind of I think a great analogy for life, because massive changes don't happen quickly. And if they do, there's normally chaos.
Absolutely.
Yeah.
And, with that, the benefit, when the Affordable Care Act came about, they deemed children's dentistry as an essential benefit. And so every kid, no matter where, how you grew up, what color your skin is, you have access to dental care. And we were really happy about that. We're really happy, we're going to take care of kids, and you're going to stay out of our private practices for adults because, I don't want the government coming in and telling me what I can and can't do and how much I should charge for things. Okay, that's how I felt, and that's how pretty much the whole profession felt. Yeah. But I feel like we missed a pretty big opportunity there as far as essentialism. But in the meantime, so we've got a completely unregulated system. Okay. And we've been doing a lot of things to try and create regulations around that. And so the big thing that, I'll give you the grand plan of where we're going with this is DLR, dental loss ratio. So for those that don't know about that, I'm sure most have heard, but if you don't know about that, medical loss ratio was defined in the Affordable Care Act at 85%. So 85% of all the premiums collected must go towards patient care. Okay. There's no dental loss ratio standard set. And California, 13 years ago, created the first DLR transparency law, which I thought was absolutely brilliant. Okay. And so now every dental benefit company in California had to report how much premium dollars is actually going towards dental care. And, from what I've understood is that the insurance commissioner found, many companies were in the 80 to 85% range, but many were in the 20 to 25% range. So meaning 20% of the benefits collected were going towards dental care. 80% were going towards, lining their pockets. Yeah. And the insurance commissioner said, hey, bad actors clean up or get out. And so many of the bad actors left. Okay. But it still did really improve things, maybe not. Okay. And so then, fast forward to a few years ago, Massachusetts came up with a very defined dental loss ratio law that they pushed through and successfully, got it passed through a ballot initiative. And ADA, I was on the board inside the decision room. And, we decided to fund that to the tune of $5.5 million to help, get the word out there. And we were just jumping for joy when 71% of the voters in Massachusetts voted for it. Okay. That's a mandate. Okay. That's a big win. That doesn't happen. Okay.
No, that doesn't happen. Anything over like 52% is a landslide.
Right.
Yeah.
And so that costs a lot of money though for us. And, we don't have the funding to provide that for every state, but we think DLR is a good thing because it will, in theory, try and improve utilization. Okay. And so we want to get DLR something around the country. And we took a lot of flack for, that because it didn't meet the exact standards of what happened in Massachusetts at the 85% range.
Right.
But, it's a non-starter in many states. If you can't even have the conversation with the legislators, you got nothing and you got no chance of getting anything. And so we try to create something with, the industry, where we could, get some things passed. And, we have it in several states now, dozens of states across the country. Okay. And so that's part one. We get that, generally around. Part two, then, is we will show them that it will not improve utilization to the level that everyone hopes it will, because the plan design is designed to not use. And we learned this while I was on the Council on Dental Benefits, where we did a deep dive on, the plan designs, because we were looking to introduce a plan that would, go against the norm and we'd be able to control it. But we found that it was really hard to do that, and we couldn't get it to work actuarially. But we learned that the 100% for preventative, 80% for minor restorative and minor procedures, and 50% for major procedures didn't work. Less than 6% of the people who have this plan with a $1,500 max ever reach their max. 94% don't reach their max. And this is a stat that's promoted by the National Association of Dental Plans. It's not our work, it's their work. And it's year over year over year. No one reaches the max, because when it gets to the 50% range, okay, the high dollar things, the crowns, the implants, the root canals, the periodontal surgeries, and when it gets to 50%, the patients get really reluctant to for the out-of-pocket costs.
Right.
And they put the money back in their pocket and they walk away, and they show up a couple years later for an extraction. Or they leave money on the table. Well, I'll just wait till January when I get a full benefit again. And we say, oh yeah, it's a good idea, we're going to maximize, but it leaves money on the table. So 6% ever reach their max. But we'd modeled that if it went from 100%, 80%, 50% to 180-80, utilization would go way up because the less copay out of the patient's pockets, they're more apt to do the more complex and important procedures. And so that would be phase 2. Once we get DLR, then we push for 180/50 to 180/80. And then we see that the utilization is going up, but it can't really do much because the max is so prohibitive. Then we go after the max and truly, raise it. Right now they see, I get complaints all the time. Well, the ADA is not pushing hard to change the max. They haven't changed the max since 1972. And the insurance company says we have no reason to. Less than 6% of the people that ever have it go to it. So we can put 5,000, it would still be the same. So now we would force that. Okay. But that's a long game. And, we've got 50 states, 50 insurance commissioners to lobby that too, 50 legislators to lobby that too. Okay. So, let's look at other ways. So then, back in 2019, my first year on the board in December, my very first board meeting, we decided to jump on a lawsuit against Delta Dental to fight against their monopolistic practices. So 2019, it's 2026 now. We're 7 years into this. Okay. Just this year, they declared that it's not going to be deemed a class action lawsuit. Okay. And so now each state now is going to have to do that individually, but it took almost 7 years for the judicial system to opine on that.
And how much money involved in that too?
Yeah. Right. Yeah. Okay. Millions and millions of dollars and hours put into this over time, depositions and getting copies of all the documents that we have for the depositions and the cross-examination. I mean, so that's not working very well. So then last year we took, we challenged ERISA. Okay, ERISA plans are federally administered plans. Okay, so you got a DLR in your state, and then an ERISA plan, because it's federally administered, comes into your state and says, we don't have to go by your rules because we're federal. And so we've gotten, different rulings by the courts because we've challenged it. Some courts said that ERISA plans must abide by the state rules, and then another court says it doesn't have to abide by it. So we decided, we're going to go to the Supreme Court and have them make a decision. And so we did. We brought it to the Supreme Court, and you know what they said? No decision. We're not going to make a decision. Okay, so we're getting blocked everywhere we go. We can't fix this through legislative means. That's why I'm saying we need to blow it up and find new ways. And this is where I think the most exciting thing is coming in with new technologies. Okay, we got all these new technologies coming in that can improve efficiencies in how we do our benefits. Okay. And there are companies in there that are gonna rock the insurance industry's status quo. Okay. Because they can do it for much cheaper and much better. And then what if we tied, the medical insurance as a way to provide dental services. So we did some pilot studies to expand some of our dental benefits into medical testing, like A1C testing or saliva testing, genetic testing, microbiome testing, airway testing. Imagine if we jumped into airway. That's medical dental integration. We jumped in, but imagine if we can, when we send our patients home with the sleep tests and we see that they've got sleep apnea based on how many aptic episodes they have per hour of every night of sleep, that they're not getting any sleep. Why do we need a doctor, a physician, to say, he needs a sleep apnea appliance when we could do it ourselves? Okay. And so it's like those kind of things are huge opportunities for us to really, expand what we can offer our patients. Like if A1C testing were a benefit covered by our benefit plan, every single patient in hygiene, every single time they come in, we get a glucose monitor test. Absolutely. Okay, every single one, but it's not covered, so we don't do it. And so we have to expand this. And so we're doing pilot programs with that and working with, and then there's studies that show if you get the oral health side healthy, the medical side will save a ton of money. And so medical insurance plans are looking at, adding dental benefits for that purpose, that it's a loss leader. You invest in oral health, much less cost on the overall health side. So that's where we're going.
And the body are connected?
I read about that somewhere. I think it was Cracked magazine. The cartoon. It was a cartoon. Yeah.
Okay.
So we're working hard. It's just it's not easy, and as long as we have, as long as they have a 90% market share of providers, they can pretty much do what they want, and they continue to do that. And what I'm scared of is that, when, membership at ADA, has been declining over the past, 15, 16 years.
Yeah.
And, when we fall below a certain threshold, we can't say we speak for the profession anymore. But who will say they can speak for the profession? The insurance industry. Mm-hmm. They've got a 90% market share, and they could start doing it. That scares the heck out of me. So at very least, members, we need members to, for just from critical mass, that we may not be able to do everything for everyone that you want, but we're the only game in town that has a chance. And we've made so many amazing strides these past couple of years. And we're on track to make some huge ones this year under Dr. Rosado, who's our current president. So,
who is also a great guy.
Also a great guy.
Yeah. Challenge anybody that's not a member. When was the last time you heard a discussion like this? Because this is the kind of stuff that happens, deep dives into this kind of stuff. You don't get together with your friends, at a study club or meet in a sports bar and have a couple of cold ones and talk about these kind of things. I mean, this is the kind of stuff that organized dentistry does all the time. Yeah. It's just, you don't see it. It's like doing a really good root canal, and patients don't talk about that. They'll talk about the ones, that hurt or whatever, because we tend to, I think as human beings, we tend to emphasize the negative and not emphasize the positive. It should be flipped. But this is the kind of stuff that the American Dental Association is doing for you all the time, but you just don't see it. And I mean, obviously you were on the Council for Dental Benefits. Is that what it was?
Yeah.
Yeah. And so you are incredibly well versed in this, but he's not the only one, folks. There's a lot of people on that council that are doing these deep dives and are fighting for us. And I mean, that's the message. Brent, I wanted to ask you too, real quick, because you talked about the membership numbers going down.
Yeah.
I've always wondered, does this seem to, and this is not a bash on anything, I'm just curious, does this seem to dovetail into the whole thing of DSOs? Do you think it's corporate, like corporate doctors are thinking, I'm working for a big corporation, why do I need to be concerned about dentistry? Is that kind of, is that sort of when it started? I don't even really know, honestly.
Well, we take it two ways there. I get asked a lot of time, or I get accused of supporting DSOs. I'm pro DSO, right. And I'm pro dentist is what I am. Yeah. Okay. Yeah. And I want to make sure that every single dentist is supported, no matter what practice model they decide to practice in. Okay. And so when DSOs came into the market, just like it's a classic economic story. Okay. When a disruptor enters the market, the status quo digs in and tries to keep that disruptor from happening. So DSO is a disruptor, and the status quo, dug in. Okay. Right. And maybe some of the actors in the DSO world were not so good at dentistry, and they were, more profit driven than best interest of the patient. But that gave many DSOs a bad name. And I saw a lot of really awful dentistry out of some DSOs, but I saw a lot of really good dentistry out of some DSOs too. Yeah. And I've seen some really awful dentistry out of some private practices. Yeah. Yeah. And I've seen some really good dentistry out of some private practices. But the problem in the DSO is that you are part of an organization, and so they will be judged by the least common denominator. And so they got a bad rap, and they were not welcomed in any community. Okay. And that really, so the DSOs are like, well, they're anti-organized dentistry because we were anti them. and we try to, I tried to, rekindle and find ways we can work together, because they do offer their dentists, especially the new dentists, all sorts of things that help them in ways that, benefit them immediately. And we don't. Okay. And so we have to find ways to do that. And sometimes it means working together with them. So we can work mutually, in the best interest of, so the ADA's mission, I'm going to say that, is that, ensuring member success and improving the lives and the health of the communities that we're serving. Okay. That's our mission. It's a dual mission. It's not one before the other, one more than the other. It is both. And I feel like if we can find ways to improve the health of the communities we serve, that every member will be successful. And sometimes that means different than the kind of practice I had or the kind of practice you had. Sometimes it means, higher volume. Sometimes it means, maybe not using, the latest and greatest materials, because they're higher volume. And, but it's, bottom line is in a public health, scope of things, we're seeing improvements in health when we can provide access. And, and I went to one of the first DSO conferences the California Dental Association put on back in like 2012, 2013. And they put a bunch of young dentists up on the stage, and they talked about why they joined DSOs. And they joined them because they got a guaranteed income. They got health insurance. They got vacation. They got mentorship. They got training. And, but if they wanted to join my private practice, I would put them through the ringer. You're going to have to earn your stripes to be to be able to do these kind of practice, under me, and blah, blah, blah. And that was the general rule. And, but then the sentiment amongst the leaders at that time was, well, the dentists, young dentists, they'll work there for 3 years and they'll come and join our practice. They'll be in private practice soon after. And I'm like, but we're bashing them for 3 years. And then when they go into private practice, are we going to expect them to, oh yeah, now you're a good person because you're not in that practice anymore? That's bullshit. Okay. Excuse me. I shouldn't say that, but I do. So then, and I looked at my practice, and I came, and I was president of the Colorado Dental Association at the time. And I said, if I were to hire somebody, especially right out of school, they have some clinical skills, not great yet, but they got good skills, but they're not where I am. So I'm going to have to mentor them. They don't have the communication skills or the confidence to be able to sell complex cases. So therefore, I'm going to have, if they want $100,000 in salary, I'd have to have $400,000 of dentistry lying around. And so they can eat, okay? And I have to invest in them. And so I asked my group, my leaders, I'm like, who's got $400,000 of dentistry lying around? Raise your hand. And none of them raised their hand. I'm like, shut up then. They need to find work. They need to get their drill spinning so they can build their skills and build their chops and get an income. Okay. Let them be, support them and mentor them and embrace them as our colleagues. Okay. And people will go into DSOs even now. They stay longer, or they go in later in life because they don't want to deal with the administrative burden of running a practice. It's hard.
I said for years, it's so true. So I got out of school and I bummed around for a while. I worked part-time in a practice as an independent contractor because I was trying to find where am I going to go. And then I started from scratch a year after this independent contractorship. But I had a lot of friends that, started working for older doctors. And this is no joke. I have said for years, dentistry is the only profession that eats their young.
Yeah.
It was this thing of you'll work the worst hours, you'll see the worst patients, you'll do the least, compensated procedures. And then someday all of this will be yours. And I'm like, as opposed to you come out, you work for a corporation and you walk in the first day and they're like, we're glad you're here, doctor. What can we do? And it's not like, go scrub the toilet. They actually give them things to do and it works with your skills. And I mean, why is that a bad thing? I totally agree with you.
But then, so people complain about DSOs. Well, they're so money driven. And I'm like, well, your private practice, you don't want to be profitable? excuse me, you and so, but then it comes into like, when private equity enters into the equation. Okay. So private equity has goals their goals are to create multiples of the investment.
Right.
Okay. And I think there's a problem with private equity in healthcare, because it can't be in the best interest of creating multiples. It has to be, everything we do has to be in the best interest of the patients. And so one of the best things Rosado did, the current president, when he was president-elect, he was the chair of our Council on Ethics Bylaws, and he wanted to create a clinical autonomy statement. Okay, that basically says that everything you do as a practitioner, everything you do as a dentist is in the best interest, mutually defined by the patient and you, in the best interest of improving their health, not in the best interest of improving the bottom line of the practice or create multiples and things like that. And we're hoping that this white paper that they created under Rosado's direction, that every dentist can use that as a bargaining tool, as a standard for what should be in the practice. in the contract for employment with that practice. Okay, that this is how, where an office manager can't say, and this happened to me, where an office manager, I was working temporary before I moved to Colorado. An office manager told me I was doing way too many crowns. It was a capitation type place. And I said, well, can you be more specific? And she pulled up an x-ray with of a tooth that I did a crown on. She's like, this tooth should have been a filling. And I said, well, what dental school did you go to? And she cut a check and told me to get the hell out. Okay. But that's what these young dentists are being faced with. Okay, because they need to work, but yet sometimes they get undue pressure from non-clinical, personnel in the best interest of trying to create profits and things like that. And that happens, but it happens in private practice too. But then, private practice world, we are siloed in our own little fiefdom. But I'm starting to see, organizations like the Academy of Private Dental Practice, the like Smile Source, who are, really investing in trying to provide the resources so the private practices have the tools that they can thrive as well with business efficiencies and buyers groups and opportunities and scale and things like that. So it's good to see that's happening and becoming bigger and bigger. And ADA is partnering with organizations like that, so we can ensure that every dentist has resources, no matter what type of practice model they decide to choose.
And when I graduated dental school, I believe, I don't quite remember, but I think the requirement was I had to do 75 amalgams and 30 composites to graduate.
Yeah.
You know how many?
Did they have composites back then, John? Did they have composites back then?
Okay, smart guy. They did, but if you got any etch on the dentin, you failed.
Right.
So I had to do 75 amalgams, 30 composites. Do you know how many balance sheets I did?
Right.
And so, and that's, I think, part of the thing is people don't have any business understanding.
Right.
And, so then when people come in to the profession and they do have, money knowledge or business knowledge, but no dental knowledge, it just becomes like, bam. But, working together, I can't remember the requirement for endo. I think it was like 6 root canals, or maybe it was only like 6 canals. I don't remember when I graduated. But you know how I got to really enjoy endo was a couple of endodontist friends of mine, independent of one another. They're like, let's get some extracted teeth and let's do some root canals on a Friday afternoon. No, you're pushing too hard. Do the, and so just like we can mentor each other clinically, people that have business knowledge can help you be better at your business.
Right.
A lot of dentists think that doing this is equal to, doing that. And it's not. We've got to understand these pieces and work together. I love the whole thing of the statement of, it's all about the patient. And it should be. I mean, as practitioners, we always walk that tightrope between how much have we spent and how much did we produce. So you need to stay in business. I've said for years, you can have the best hands on the planet, but if you can't stay in business, they're not going to help anybody.
Right.
So, this whole thing of working together, learning, from other organizations, all that kind of stuff, I'm all in for that. I mean, I think it's important.
Yeah, and what I see the ADA doing is being a convener of the experts and all the niches of the profession, and and we want to entertain conversations and share the resources and the betterment of achieving our mission, member success and improving the health of the communities we're serving, and all boats will rise with the rising tide.
Yeah, and the other thing I think is kind of cool, just kind of going back to the very beginning, is I talked about my friend Dr. Sabatez that I went to dental school with. His family escaped Cuba when Castro came to power.
Yeah.
And he grew up in Florida, and here's this kid, whose family were refugees, ended up going to dental school, and then ended up being the president of the American Dental Association. And you, with this incredible story you've got, rising to that same level. I mean, dentistry provides the dream. I mean, I had a great privilege 3 years ago I sold my practice. Now I work for the new owner. Sold it to one of my best friend's daughters. And the thing that really gets to me when I talk about doing that is I gave her the dream. I mean, I got what I wanted. I got my dream. And then dentistry allowed me to give somebody else their dream. I mean, how amazing is that?
On so many levels, John, that you got to pass that, the business off to someone so they can, create what they wanted to, what they set out to do.
Yeah.
But think about all the millions, I'd say tens of thousands of patients that you treated over the course of your career, that you've improved the lives over, that you got to see them over decades and their families and they knew you as a person of trust in the community. And that's what it means to be a professional. You were the epitome of that in your career. And that's most likely for me, that was when I was most proud of and is what I've been as a dentist. It wasn't the doctor in front of my name on my card. It was the impact I made on the community and the impact I made that I gave my staff, my team, an opportunity to grow as human beings and make a living to provide for their family. And I was able to sell the practice, it's funny. My first day as an employee of the practice that I used to own, and I lived 5 blocks from my office. And I called Ben, my owner, and first day, and I'm like, Ben, I got a little frog in my throat. I don't know if I'm going to make it in. He's like, "But you better show up. You better show up." I'm like, "I'm just kidding. Of course I'm going to show up." But the weight of the responsibility was much different as an employee than it was as an owner. Yep. And I realized I was pretty burned out because it was hard.
It's very hard. And it's funny now. I was talking to Rachel, the new owner, a while back, and when I owned the practice, this is no joke. I mean, I loved it. Don't get me wrong. But every day, every work day, I did not have to set an alarm. Between 4:15 and 4:30 a.m. every day, my eyes would just go open and it'd be like, game on.
That's right.
And I was talking to her the other day because I'm sleeping. Now I got to set an alarm clock because I sleep. And the whole conversation came up because we were talking about something. She's like, "I'm tired." She's like, "I get up every day at 4:30. And I said, "Did you before?" And she was like, she kind of looks at me, "No." And I said, I can't help with that, but I can tell you I've been there and I know what it's like, So it is totally different to not have that. It's the greatest burden and also the best burden to carry.
Right. And I just want to segue that to the future. Okay, because the practices that we had are not going to be the practices that are going to be in today's day and age.
Yeah.
Okay. The consumers have changed. The consumerism has changed. Technology has changed. Values have changed. The younger dentists have different values than we had. And many of them do want portability. They want to be able to experience life in different places and not be tied down to a practice as early as we did. And, and regardless, we can't, we can identify that they are different, but we can't judge them as right or wrong. Right. We just have to, find ways that they can achieve their dreams as why they wanted to be a dentist. And so we have to support that too. But I do see a big shift in dentistry happening as we incorporate more into a whole health type dentistry. I'm seeing pockets of whole health dentists opening up across the country. We're seeing, we see it in the FQHC system or the safety net systems where there's medicine and dentistry under the same roof. We're seeing it in some, large DSOs where medicine and dentistry is under the same roof. The caries rates of the current let's say the baby boomer generation. Okay, I'm Gen X. My parents, my dad, my mom had fillings placed in every single tooth in their mouth when they were teenagers. Right. And we as private practitioners spent most of our profit centers time, effort on, repairing and idealizing baby boomers' mouths. Yep. Okay. And so my generation, Gen X, we've got much less decay in my mouth than my parents had. I've got, I had 5 or 6 fillings, 2 or 3 of them have been converted over to gold onlays, and, I don't have much to do. Okay. Right. The generations below us has even less decay. And so the demand, yes, there will always be a demand for caries management, especially in the lower income demographics, okay, due to social determinants of health. The foods they eat. And now with fluoride going away, fluoride being in flux, it may go up, but the caries rates are going to be way less. And so we have to shift our practice philosophy and our paradigms from a surgical-based model to more of a management of chronic disease-based model. And surgical-based model meaning my drill must spin if I were to get paid, okay? Or I must be scraping something or cutting something to get paid, okay? But yet in medicine, they get paid for, lifestyle consultations, nutritional consultations, drug and alcohol consultations, sleep consultation, all these things. Yeah. We don't get paid for that, but we need to. But yet all of these things are absolutely essential for our dentistry to work. If we don't have oral hygiene instructions, I don't care how good your crown margins you have, it's going to fail if they don't take care of it. Okay. And it's going to fail if they eat, nothing but sugar. Okay. And so we have to have these conversations, but it's time for us to start getting paid for that. It's time for us to start getting paid for, lifestyle discussions and consultations and preventative services to a level that it needs to be. Okay. Otherwise, there's going to be a lot of people going out of business, or there's going to be a lot of like, I hate to say it, but unethical dentistry going on where we're drilling for no reason. And so technology is going to be a big driver of that. Technology is going to bring efficiency and efficacy. So it's going to be better care for cheaper. And one example of that I could say that we've all experienced was shifting over from film-based x-rays to digital-based x-rays. Okay. I was one of the first to adopt that in my part of town. And it was really expensive. And, and I don't miss the 7-minute meditation that I had to have when I took a film-based x-ray in the dark room. But the 7 minutes now turns into instantaneous x-rays right in front of the patient at a much lower exposure to, right in front of them. So now they're engaged in the process. And so that is an example of efficacy and efficiency. Okay. It's cheaper and it's better. And we're able to do more. And now with AI and new technologies that are coming on, we're going to be able to do more for less.
Let me ask you a question about AI, because this is something that I have been thinking about. So I like AI. I use Pearl's second opinion in the practice. I know that third-party payers are also using AI. And my question for you is just, and this is kind of a random throw spaghetti at the wall, but I'm just kind of curious what you think. I'm thinking it might be a good idea to have some type of a body that looks at third-party payer AIs and makes sure that what they're working with is the same data set that we're working with. Because, you know, if you tweak it to say, you know, unless it's 4 millimeters into dentin, we're not going to compensate. And we're seeing it and we're like, oh my gosh, yeah, that's through the enamel, it's into dentin. We need to restore that. But they're like, no, our system doesn't see it. What do you think of that idea? I think it's
it's already happening, John. ADA convenes the standards for everything in dentistry, and AI is one of the big hot items right now. And we did publish a white paper on standards of AI 4 years ago now. But by definition, with AI, as soon as it's published, it's already outdated. Yeah. Okay, and so standards are
it's outdated tomorrow.
Right. And so anyway, but we have a whole standards group that's both within the country, and then that usually leads to FDA regulations. And then we also have one that's international with ISO. And so it's one of the hottest topics and the most important ones that we're doing right now in the standards. ADA is convener of that. So it's happening because it has to be on.
Apologize about that.
That's okay. No, I mean, we do so much. We do so much.
Yeah.
But it has to be on a level playing field. But, you know, I'm glad to see that it's starting to take traction in the practices that we're in. I'm glad to see that it's also starting to take traction in the benefits, because right now the AI programs can battle the AI programs at the insurance place, and they're having their own little Terminator fight, and you know, and you're not involved, okay? And imagine with revenue cycle management that AI can do a lot of the work that we are, you know, have our poor dental office administrator who's sitting in the corner on hold all day long dealing with these inefficient systems that the insurance benefit companies have by design, okay? But it can be done automatically, and then you could shift that, you know, poor, you know, wasted talent person, you know, to sit on hold. You can put her into a better role in the practice where they can actually drive value to the patients, you know, and where you can really, you know, improve the visits that patients have and improve the trust that they have in you and your team, okay, as opposed to sticking her in the corner and leaving her on hold the whole time. So, you know, we're in a volatile time with a lot of, you know, technology adaptation, but it will turn into something that's much more efficient than what we've been doing for the last 25 years, 30 years.
And I think you brought up the point that I always say, which I think is good, is that it's going to make it more of a people thing. You know, we're social creatures by nature, and no patient really benefits. I mean, I guess if you really stretched it, you would say that 45 minutes or 2 hours on hold is working for the patient. But when that person, rather than being on hold, can interact with your patient base and make their visit better, help them understand things better, I mean, that's a beautiful thing to me. It's just being able to take care of the patients.
Yeah, but imagine, so right now, you use it for radiographic, you know, enhancement and detection and things like that. But imagine having AI as the most amazing digital assistant that you can ever imagine. Okay, so like I've got headphones on, okay, and I'm going from op 2 to op 3. And as I'm walking into op 3, my AI assistant is telling me, you saw Mrs. Jones 6 months ago for a cleaning. At that time, you did 2 fillings. One of those fillings was a little sensitive. She came back twice for adjustments. We haven't heard from her since. They've got 3 kids, a dog named Spot, and they were planning to go to Disney since last time you saw them. Because this is the stuff we would write in our charts, right?
Oh, yeah.
Okay. And so it saves me from running back to my office, finding where I wrote it in the chart, whether it's on a digital chart or a paper chart. And then I come back in and act like I remember this. Okay. But it's happening as I walk in and I start the conversation in that realm to drive more trust in the doctor-patient relationship. Okay. Yeah. And then as we're getting into the dentistry part, the AI scribe is taking notes and formulating my practice note or my procedure note for me to review later and modify and teach my AI how I want those practice notes to be. Okay. Talk about efficiencies. Okay. I mean, that's possible. That's happening right now.
Yeah. And
welcome to the 21st century.
Yeah. And then you with that patient and you say, okay, well, I see, I see a little area of mesial caries on tooth number 13. And then the AI comes back and says, okay, according to their insurance company, it'll be, their out of pocket will be X, they've got this much left on their yearly maximum, all of that. And you're going to need a bite wing and whatever, and be able to know all of that ahead of time. And like you said, that's happening right now.
Yeah. And not only that, it has the probability of being accepted by their insurance plan. Okay. Without even calling them, there's a probability, because I did a lot of inlays and onlays in my practice. I didn't like doing 3 surface fillings, and I didn't like doing full crowns. Okay. But an onlay gets paid, fraction of a price of a crown. Right. So most people will just do crowns, even though, so when so on that AI, it would have a probability of being accepted. And I could tell the patient, there's a very low probability, but we'll do everything we can. Okay. Yes. Do you still want to go forward with this? That kind of thing. So there's no surprises. And so, and then with diagnostic capabilities, we can train, my eyes, I can see 12 shades of gray pretty well. Okay. Right. But we can train the AI to read it at 1056 shades of gray. And what if there's a defect in the tooth that it's indetectable by my eyes, but it's there and it's clinically proven by the AI trials that we've done, okay, in the profession, okay, that it's clinically there. There's a defect, and there's an 80% chance that defect is going to turn into a filling or turn into a cavity at some point. What if you catch it at defect stage by, painting some kind of regenerative, material on there, and that patient never has to have a drill put on their tooth? Okay. And get paid for it.
Yeah, and get that's it too. And seriously, and get paid for it, because it's not all about money, but you have to stay in business.
No,
you're right.
Right. And we're very conservative, and when we see that little buccal pit on that, that 12-year-old on number 19, that buccal pit, is going to last 10 years, the filling that we're going to do. And then it's going to have to be replaced. And by then there's going to be a crack in the tooth, and it'll be replaced again. And then we'll have to put a crown on it. Then it'll need a root canal. Then it'll need another crown. Then it'll be extracted because it cracked. And then bone graft, implant, all because of that first time we put a drill to the tooth. There's an economy attached to that tooth through the lifetime of that patient, and so we can avoid that wholeheartedly. That's what prevention really is.
And the other thing that I am looking forward to AI with is the idea of being able to tell you like probabilities of things, because it can go out and, like look at practice management databases, and it will come back and say, there's a 40% chance that if you do that, it will fail. But this other treatment has a 95% success rate in similar cases, and being able to know that ahead of time instead of learning it through the school of hard knocks, it's so much better for the patients, so much less stressful on us.
Yeah.
To be able to do
better
that.
Care for cheaper. Yeah. Right. And that's, and we could do more of it and treat the other half of the country that doesn't access dental care. Yeah. Right.
If you can do something, if you could, on a good day, if I'm really cranking and busy, not counting hygiene exams, maybe 10 patients in a day. But if I could, at the same pace, see 15 or 20 people in a day, because I'm doing more prevention.
Like and there are plans that will pay for preventative services like I just described, where you paint a regenerative, material on there, and they'll pay it at the level of a one surface filling. Okay. That's happening in real world. That's what we're advocating for. And imagine doing, 10 of those on a patient in one sitting in about 7 minutes, as opposed to 10, two surface fillings over hours, and putting the patient through, getting them numb, and doing quadrants at a time, bringing them back, and the overhead goes way down, and it's efficiency and efficacy. That's what I keep saying. These new materials, these new technologies are going to allow that to happen. And so the practice must shift. And that is management of chronic disease. That's prevention. That's not surgical based. That's what I'm talking about.
What I was just going to say was the whole thing of if the drill's not spinning, the income isn't going. And it doesn't necessarily need to be that way. And I appreciate the fact that, that you guys are advocating for that, because somebody's got to. I don't have time to go to Washington, D.C. and talk to everybody. That's why we need what you guys do.
And I'll say one more thing about the future under Dr. Rosado. He's and I'm the chair of this committee, is the Oral Health 2050 project. And this is, I think, the most important thing that the ADA has ever done. And it's basically imagining what will the delivery of oral care look like 25 years from now. And so we've got, I think we've had over 150 applicants to be part of this project, and we partnered with the Boston Consulting Group that will interview everybody, and we'll come up with, some ideas of what it could look like, not what it will look like. Because if I can read the future, I'd be doing a lot of different things in dentistry. But I think, but if we can drive some imaginations of what dentistry will look like, what the delivery of oral health will look like 25 years from now, when when it happens, we're going to be ready for this, and it's going to happen quickly. And then my goal with this is to drive conversations, because there's going to be people like, oh, you're crazy. That's never going to happen. That's stupid. That's going to ruin dentistry. And I'm going to hear that. I know I'm going to hear that. Then you know what I'm going to say? I'm going to say, well, please tell me what your vision of the future is. And let's start talking about it, because the more we can have conversations about it, the more the entire profession is going to start thinking about the future, and we'll be able to drive the preferred future. And through the Darwinian, evolutionary, economics, something's going to come forward, with the best possible care that we'll be able to provide. And notice I didn't say the delivery of dentistry. I said the delivery of oral health, because it's going to be much bigger than just drilling and filling.
Well, and that's huge. Just out of curiosity, are you guys going to give tidbits as this goes along, or is this something that we've got to hold our breath for? Because I would love to know more about it.
The plan is, once we get it going, we've got 5 different panels. Okay. Education is one of them. That's a big thing going on right now. And ADEA, the American Dental Education Association, is spearheading that part. They are the experts on that. They're doing that. And then we're doing, what is the practice models going to look like? How will technology, that's one panel. How will technology and AI be part of that? Okay. What will the benefit models look like 25 years from now? And what will wellness look like? Not only clinician wellness, but the wellness of our patients and the opportunities there. So those 4 panels are what we're going to do the major work on. And as we get one project done, we're going to publish out a white paper on that panel. A few months later, we'll publish another white paper out on the next panel, and then keep the drip going over time.
Good.
So that we can have time to assimilate and discuss it. And I encouraged every single specialty organization to do the same. What's it going to look like from an oral surgery standpoint? What's it going to look like from a perio standpoint, from an oral medicine, from an endo? Okay. And so, because they're the subject matter experts, they should be looking at it too. I think it's the most important thing we can do as a profession is to create the best possible scenarios for us. Okay. In line of the mission. So, it's going to be exciting. And, I think it's going to be a lot of work is going into this, but I hope it creates a lot of discussions.
Well, it kind of ties in with the old joke, but it is kind of true. There's 3 types of people: those that make things happen, those that watch them happen, and those that ask what just happened.
Right.
And Yeah.
And I think medicine asked what just happened when the Affordable Care Act happened. Okay, when the Affordable Care Act was, because it was dictated by the government and the insurance companies, and medicine's like, what just happened? We just lost our profession.
Well, and look at the influence of unfortunately, not to denigrate them, but look at the American Medical Association versus the American Dental Association, because the AMA doesn't really have any influence anymore.
Well, I would disagree. They don't have the membership percentage, but they are still they got what we call brand strategic incumbency. Okay, their brand is still the biggest brand in medicine. Okay, and same thing with dentistry or the ADA. We're the biggest brand. Okay, so but yet they don't have the critical mass of membership numbers, right. Because medicine, different parts of medicine felt it needed to have a bigger voice. Anesthesia had a bigger voice, orthopedic surgery had a bigger voice. So, but still AMA still has a lot of influence. And, in fact, I got to serve on a panel last year with the president of the AMA and the president of the American Nurses Association. Oh, wow. It was the first time in the history of all three organizations that we got to sit and talk about common issues that we're facing from our different perspectives in delivery of health. And we're hoping that turns into, more discussions, so we can come together in the best interest of serving our communities. Okay. As president last year, so that happened. I got to, testify at the White House about, the MAHA project and where oral health fits. I got to go testify at the Environmental Protection Agency, the APA, the FDA on fluoride, many times through Congress and many times through, U.S. Congress, and then at the state level as well. And I got to support all of these leaders across the country as they did their part in advocacy, because there's not enough dentists in legislative roles where they can make a difference. Right. But so we are obligated, because we're governed by these laws, we are obligated to share with our legislators, those who make the laws, what the best practices are. And because so we are a team across the world that do this, and it's amazing.
I mean, like I said, we've got to do it, because if somebody came to me and said something like, "Oh, we're gonna like redesign the traffic in your city," I mean, you wouldn't want me to do it.
Absolutely not.
Kind of, unfortunately, what happens sometimes, is that if people are given a task and they don't know a lot about it, if nobody provides input, they just do the best they can with the data they're given. And, I mean, everything.
Right, the loudest voice, the squeaky wheel is what gets the attention. And so, again, we have to be that loudest voice for the sake of the profession.
Brett, we've been at this a long time. I probably ought to wrap. This is
we could talk for hours, John.
You know what? When you get a second, why don't you come back and do part 2 with me? Because I would love that.
Awesome. Right. I'd love to do that too.
Anything you want to say to close out?
No, just thank you, John, for all you're doing and giving me this opportunity to share a lot of things that the organization is doing. I feel that the golden age of dentistry is right in front of us, and it's time for us to create it. And I'm excited, really excited. So I hope that came through in our discussion today. I feel like it did.
Just a little.
Yeah. Thank you, John.
I want to say thank you. Number one, for spending this time, because we'll do more. But thank you for, what you did and are still doing. It's sometimes tough. What's the old expression that if you lead the charge, sometimes you get shot in the back by your own troops. And that's it is truly, it's a tough job, but I'm grateful that you did it. So thank you for that.
I appreciate that. Thank you.
Everybody, thank you for watching. Stay tuned for part 2, because I'm definitely having this guy back to talk some more about some stuff. So this is the Technology Evangelist podcast. I'm Dr. John Fluke, the Technology Evangelist, and I want to close out by thanking Medidenta for their support of this, because if it wasn't for them, I wouldn't be here. I couldn't do this without them. Be sure and like and subscribe. If you have a comment, throw that in the comment section. We're wrapping up for now. We'll see you next time.
Thanks, everybody.